Yes,
Jamal?
I think you should go ahead. Go ahead, please.
All right. Good evening, everyone. It's give me a great pleasure to introduce Professor Michael Lichtenberg to start our first webinar meeting for 2024, run by PAVSS, Vanilla Vascular Surgical Society. Professor Lichtenberg is the Chief Medical Officer and Director of the Angiology
Recording in progress.
and the Angiology Department at Vascular Center at Arnsberg Clinic in Arnsberg, Germany. He get his MD from University of Düsseldorf, and he studied at Tulane University of Medicine, New Orleans, and Texas Heart. He's interventional angiology for 20 years, and he's managing director of the German Society for Angiology in 2017. And 2019, he was elected to serve as society president for period 2020 to 2022. His area of interest is mainly the deep venous intervention, peripheral arterial disease, peripheral thrombosis, and atherosclerosis. So it gives me great pleasure to introduce him to talk to us about a very controversial, really, subject with deep venous arterialization and how we do it, some tips and tricks. Also, I'm going to introduce our panelists. Sorry. We have Dr. Carlos Bichara. He's a professor of surgery at Loyola Stritch School of Medicine, Maywood, Illinois, and he's co-director of the Loyola Center of Aortic Disease. We have Dr. Hani Zaid. He's a consultant vascular and vascular surgeon at Gates and St. Thomas NHS Foundation since 2008, and he's head of lower extremity revascularization at Gates and St. Thomas Hospital. We have Professor Jamal Hubballah. He's chairman and professor of surgery at the Department of Surgery at the American University of Beirut. We have Dr. Martin Marish. He's from Slovakia. He's a senior consultant vascular and endovascular surgeon at Bahrain at the Defense Force Hospital, PDF. And then we have Dr. Muhammad Omar Farouk. He's a vascular and endovascular surgeon in Cairo. So it gives me a great pleasure to introduce this panelist and our speakers to talk about deep venous arterialization. Professor Lichtenberg, you can start, please.
Yeah, thank you very much, first of all, for the invitation. Thank you very much for this very friendly introduction. It's great to see so many friends here, and it's a pleasure to discuss with you today about deep venous arterialization. I think a very important topic to discuss on and how we can offer no option patients nowadays an option to prevent major amputation. So let me start with a small introduction before we really dive into the technical details of deep venous arterialization. I think we are all aware that critical limb ischemia destroys life. This is known for many, many years. More patients die within 5 years of a CLTI diagnosis than with any other type of cancer except for lung cancer. And this is a dramatic situation in every country, not only in Europe, as well in your area, of course. And we all have, I think, to stand together to improve this dramatic situation. And we know that especially patients who have already undergone endovascular procedures, surgical bypasses, conservative treatment, the outcome at the end, especially of no option patients where we can't offer any of the established technologies, therapies, these patients are on a super high risk to be amputated within 1 year after this dramatic situation. So the no option chronic limb-threatening ischemia is the topic we want to discuss today. And yeah, what is a non-option patient? A non-option patient is clearly a patient who can't be offered any additional therapy. So like this angiogram here and below, no acceptable arterial target for revascularization. There are chronic wounds which typically do not heal without any successful reperfusion. This is a no option CLTI foot we define as of today. In the past, and this is a little bit, dive into historic development, there were already ideas to combine surgical approaches with endovascular approaches and to offer patients options. Here, this is a very old publication from 1951, which I found just to do a side-to-side operation between the proximal artery and the vein. And of course, this would never ever have a good outcome, of course. Every patient had to go on amputation when we just connect an artery and a vein in the mid-thigh. But it was, let me say, the first step into this direction to perform deep venous arterialization. Different other authors and publications followed. In 1971, Professor Lengur described a new surgical technique of venous arterialization in a few diabetic patients. He used the great saphenous vein, the GSV, and inverted and anastomosis this proximate to a donor artery, and distally to the supramalleolar segment of the same vein. Of course, he was not able to do a valvulotomy by that time, so the blood never reached the foot and forefoot, but it was the next step towards venous arterialization. And this over time improved more and more than with a very distal bypass anastomosis. So getting into that area and field, and we can discuss later on about this, into full surgical venous arterialization with very distal bypass anastomosis and some kind of valvulotomy. And this then was, I think, the step towards the hybrid venous arterialization. Some meta-analysis already were published a couple of years ago in 2016. For example, from Dr. Schrever, he's from the Netherlands. He analyzed 15 studies with close to 800 patients and showed that the venous arterialization for salvage of critical ischemic limb was already an option and described in many smaller trials and publication, and showed a very good limb salvage actually of 75%. By that time, of course, the endovascular procedure was not established, but again, it was a clear step into that direction. And nowadays, and this is the yellow part here, we are talking about a pure mechanical venous arterialization procedure. So full percutaneous arterialization, including steps like ballooning, valve lysis, stenting, and maybe a staged calling. And this is the topic I would like to discuss with you today. So these are the patients, and these are the patients we are dealing. And this will also be one of the topics. What is the best patient for deep venous arterialization? I think a very important aspect when we talk about DVA, because not every patient is definitely a candidate, and we have to define what is a candidate because we want to have a good outcome. We know that especially these desert foods have bad outcomes. So if we leave these patients on its own and offer them not any possibilities, they will be amputated in many, many ways. So the one-year limb salvage based on studies is pure. So there is no alternative. These no-opt patients need something, otherwise they get amputated. So this leads me now into the different aspects of transcatheter arterialization of the deep vein, the TADF procedure. So a permanently bypass for patients with no option situation. And these are the three important integrated system steps we need to know to perform a successful transcatheter arterialization. It's the AV crossing step, it's the valvulotomy step, and at the latest step, the stent implantation, here shown with the three different technologies, especially the existing technology what the lymph flow system is offering, and this I will now cover and show you for step. The first step, to give you an overview, is always the pedal venous access, shown on the first slide here. Once you have access to the venous system via ultrasound-guided pedal access, I'll show you this in a more detail and show how you can easily perform this. A pedal venogram needs to be done to identify the best deep venous vessel you could use for AV crossing. Then you perform an AV crossing with the needle biopsy into the vein. And then, of course, after crossing, you have to perform the valvulotomy so that you can establish an inflow via the deep venous system into foot and forefoot. And to secure this vein from recoil and closure, at a later step, you need to do a tapered stent implantation after implantation of a long stent implantation to secure the AV fistula. And then you should have a very good venous arterization achievement. So who is a perfect or who might be a good candidate for the venous arterization? We know that these patients are typically very sick, so they have a high level of comorbidities, including diabetes, smoking, hypertension as well. We know that most of these patients, I would definitely say more than 90% of these patients have a non-healing ischemic bone, so Rutherford 5 patients clear. Just as a remark, Rutherford 4 might be also an indication, but we come to this point later. But some patients with contralateral amputations due to CLTI also makes these patients on a high-risk patients. So we need to define these patients and, of course, have this patient in a general view, because these patients, beside of their vessel situation, have a significant comorbidity situation because of comorbidities as well as myocardial problems or any other general issues. Based on the existing technology and data we have for this technology, you can see here the clinical program, especially for the lymph flow procedure. Everything started in Europe with the international study, the PROMISE International Study, where also Hani is conducting, gave us patient into this trial. So 20 centers, 62 patients were included. Then a German and Netherlands cooperation study, the ALPS registry, was organized with a 24 months follow-up of these patients who received venous arterization. And then the US success study started with the PROMISE-1 trial and the PROMISE-2 pivotal trial, which was recently published in the New England Journal of Medicine, which then directly led to the approval of the venous arterization with the lymph flow system in the United States, which was then followed by the acquisition of Inari of the lymph flow company. The PROMISE-1 and the ALPS study, so the first trial which were published, showed a very durable outcome out to 24 months. You can see here in the PROMISE-1 trial, 32 no-option patients were included with a limb salvage of 77% and a wound healing situation of 85%. Very sick patients and very complex patients with critical limb ischemia were included. On the right side, you see Rutherford 5, 87%, and even Rutherford 6 patients with 13% were included. The multi-center ALPS registry, where, for example, Professor Scheinert and Andrew Schmidt included patients, showed a limb salvage of 80% and a wound healing situation of 73%. Here you see the lymph flow clinical data for PROMISE-1 and the ALPS registry in terms of limb salvage. And you can see after 24 months follow-up in the PROMISE-1 trial, a limb salvage of 77%, and within the ALPS trial, a limb salvage rate of 80%. And I think these data are absolutely fantastic. Again, as we know that no option patients were included, no other possibilities to prevent amputation. So a limb salvage rate around 80%, I think, is really an impressive outcome after 24 months for these patients. Again, then from Europe, the trials were then organized in the United States. So the story went to United States with the pivotal trial. The national PI, Dr. Dan Clare and Mehdi Shishipur, they included 105 patients in 20 sites in the United States. The primary endpoint included amputation-free survival at 6 months and secondary endpoint, of course, as well, technical success and wound healing. And I will go to this data a little bit. You see the publication on the right side, which was published by the end of last year in the New England Journal of Medicine. So in terms of primary endpoint, 6 months amputation-free survival, limb salvage survival, you can see that the amputation-free survival was 66%. So still very positive data, even that the time was very challenging when they included these patients during COVID. So these outcome data were influenced also by COVID deaths, but still with that, they had a very good amputation-free survival of 66% after 6 months. And in terms of secondary endpoints and outcomes, you can see here limb salvage 76%, so survival rate 87%, and technical success, I think that is very important to mention, 99%. So from an endovascular standpoint, you can say that mostly every approach was successful, and this is very positive, I must say, especially for these patients with very complex critical limb ischemia situation. In terms of durability of the limb salvage, you can see here the Kaplan-Meier estimate, time after index procedure, limb salvage rate 69%, and this corresponds very well to the ALPS registry, the PROMISE-1 trial. So we are on the same page also with this PROMISE-2 US trial. So another proof that this full endovascular approach was very well to prevent major amputation in this patient. Also secondary endpoint analysis showed a very good improvement in terms of pain resolution and Rutherford class improvement. On the left side, you can see after a couple of weeks of still high level of pain, this pain scale dropped down over time, and this is typical and can tell you after more than 40 cases now that this is really true in the daily routine practice. It takes a while to improve the pain in these patients, but then they definitely improve over time, as you can see here, and this corresponds very well to my daily routine practice. And it also takes time to improve the clinical bone healing situation in terms of Rutherford classification. Couple of weeks, you definitely need to focus on these patients for bone healing until the bone healing process really improves and the bone start to heal. And this is what is shown here in this PROMISE-2 trial. So therefore, it is important to include perfect patients who have a real good situation in terms of bone healing and in terms of pain relief. And therefore, patient screening is very important. And in the past, we were a little bit, let me say, negative about patients with dialysis and patients with Rutherford 6. When we started with that, at least in my center many years ago, we started definitely not with dialysis patient and Rutherford 6 patients, but nowadays, if you screen these patients, especially Rutherford 6 patients, and the bone situation is still something you can control without a significant infection, also Rutherford 6 patients can be included as a patient for endovascular deep venous arterization. Another trial which really was very important to learn more about patients with no option was the Clarity trial, which did not focus itself on the endovenous arterization, but on the outcome of patients with critical limb ischemia. And this Clarity trial, which included 22 sites in the United States with 180 patients, was a prospective single-arm trial and was an observation track the clinical progression of critical limb ischemia patient and the incidence of death, amputation, revascularization attempts over 12 months. And this Clarity trial was showed us the truth of these patients in terms of amputation-free survival in the option patients at 38%. Yeah, so a very good monitored and controlled trial, which showed us that these patients without any options, without any further treatment, have a super high risk of major amputation. And therefore, this clarity trial was a proof trial that we need to treat these patients and help us much to then decide to include patients in deep venous arterization procedures. So the conclusion from the clarity trial that provides an exciting data set of real-world outcome, and that 62% of no-option patients received a major amputation if there is no other option. So a clear message from this trial that these patients are on high risk. And I think this is something especially the FDA then understood that there is a need for deep venous arterization and the approval. So that means if you improve the clinical situation in these patients with deep venous arterization, there's a high potential to prevent amputation. This is shown here, the PROMISE trial. I think together with the CLARITY trial was one of the big arguments for the FDA for the approval. You see the significant improvement for patients who received deep venous arterization. So therefore, the message is clear. Deep venous arterization for no option patient is something we should need to offer. Therefore, it's now time, I think, to guide you to the different steps of this lymph flow procedure. Key and important factor is patient selection screening, because not every patient, as already stated, is a patient for deep venous arterization. A deep venous arterization is not like a standard SFA recanalization, BTK procedure, ballooning, or stent implantation. It's a process. It's not just a procedure. It's a process, not an event. And it will take a lot of efforts, not only by the physician as well as the patient and maybe the family, to bring this patient into such a procedure event and guide this patient and follow this patient, especially after the intervention, because the intervention is just the first step. The real complexity starts after the intervention. And this is the reason is simple. It's about the bone stability, and the location is something we need to screen. We have to take it as a key part when picking an appropriate patient to treat this patient with deep venous arterization. Of course, from a technical standpoint, anatomy is very important. This is something we need to have in mind when we screen patient. We need to know about inflow disease. We need to know about native tubule supply, about the target vessel, and of course, and this is important and key, foot vein mapping by ultrasound. And of course, as already mentioned, after the procedure, we have to organize together with the patient, the whole family, the ambulatory setup, a good follow-up of these patients, especially as wounds can change, wounds can decrease in terms of clinical severity. Patients are on the high risk for superinfection after revascularization of their wounds. So a very good setup is key and important. So therefore, wound assessment, and then we start with that, is one of the most important aspects before we really decide this patient might be a candidate. And therefore, I would like to show you and give you some hints, tips, and tricks, which are, in terms of wounds, good candidates for deep venous arterization. So every wound distal to this green line is a good wound for deep venous arterization. So this is the green area, mainly toes and distal metatarsal region. When it comes more to the mid part of the foot, the metatarsal region, these patients might be a candidate. It really depends how much tissue is salvageable. This is important. So it's not a no-go, but these patients need to be screened, and they need to be answered, do we have a chance that this tissue will heal over time after venous arterization? Patients with heel bones or ankle bones definitely are no candidates for deep venous arterization. These are the red area, which I would like to show here. So the next step is, of course, the fluoroscopic assessor, and to define where we can cross from the artery to the vein. So the most typically used artery is the posterior artery, as you can see here. The peroneal artery might be a second option. My personal favorite is the posterior artery, followed by the tibial-peroneal trunk. Here you have very good possibilities to cross from the artery to the vein. So therefore, a diagnostic angio is, in my end, in my opinion, before you start for deep venous arterization, a must to define the artery situation, the anatomic situation. And we need at least 2 centimeter landing zone for the tapered crossing stent. And this needs to be defined before we start with the journey. So this is the arterial side, but then of course we need to focus as well on the venous side. So duplex ultrasound is important before and during the intervention. So we need good venous vessels to puncture and at least to use these venous vessels to supply the blood to the foot. These venous system should not have any previous thrombus or deep venous thrombus before. So we need to rule out with the compression ultrasound that here is a significant disease of the deep venous system before we dive into that. And therefore it's mandatory to do a very good ultrasound before we start with the procedure itself. The typical vein we use for this venous arterization is the lateral plantar vein, which you can see here on this anatomic reconstruction. And this is the area where we then puncture from distal to access to the deep venous system. And I'll show you how we do it here. This is, by the way, Stephen Kump, and he explains how to do this. So this is the optimal situation. We have a patent lateral plantar vein. It's the area we can puncture and then puncture the vein to get access from the distal vein to proximal. So when we prepare the INEX procedure, we of course need to follow some rules and recommendations. First of all, we need of course to have a good access sheet from the arterial side. So a 7 French long sheet is, from my opinion, a clear recommendation. And to bring in the arterial crossing catheter, it's important. Some colleagues use even 8 French catheter. So 7 French is the minimum. You need a sterile S-match or sterile pneumatic cuff to perform a good filling of the venous system, the deep venous system. You need to have specialty guide wires O18 and O14 to perform a crossing and to guide through the deep venous system and the arterial system, of course. For the crossing itself, the needle biopsy, non-hydrophilic coated wire is recommended. For example, just an example which we use in my clinic is the nitrix wire. Highly recommend as well an angiographic ruler to define the crossing area and to find it during later steps. Then, especially for guidance, you need some guide catheters, support catheters, a Navicross or any other. You need PTA balloons to balloon the deep venous system after valvulotomy and to perform a good angioplasty, especially also for the inflow and the crossing area. Potential extra use, of course, are scoring balloons, drug-eluting balloons, whenever it comes to a stenting proximal to the AV crossing area. I use, especially P3 segment, superior stents, which seem to work very well in this area, of course. And if needed, and a very important step at the latest part of venous arterization might be to embolize one of the side venous branches, so that you can really achieve a very good direct inflow without any loss of inflow during side branches. So there might be an option that you need to embolize side branches in the venous system. You see how we place the ruler on the leg to define then the area of crossing. So for the venous access, we usually use a 4F sheet and a 014 guide wire. Then while using a rotation of the angiography, we try to maximize the distance between the arterial and the venous guide wire we brought into the systems, and based on the ruler then define the optimal crossing area between the artery and the vein. You see how it looks like when we puncture into the lateral puncture vein here. You can, after wiring, then of course insert a 4 French sheet, because this gives you the possibility then to perform a phlebography, as you can see here on the angiography on the right side. Very important then to define which deep venous vessel you then want to navigate to proximal with the wire. The access to the plantar vein, yes, of course, this could be challenging sometimes, but I would say after 2-3 cases, you get very used to that, and then quite easy to puncture the lateral plantar vein and to find your access to the deep venous system. And again, this is how it looks like after the access via the 4 French sheet. Of course, during the pedal maneuvering, you should take care, especially of the valves. Traversing valve against the flow can be very traumatic, and this can result in a viral diversion, especially into the tributaries. You don't want to dissect, you don't want to perforate, of course, so do it very gentle and try not to induce any perforation, and as well as with many maneuvers induce any spasm. So additional to very careful wiring, please apply some vasodilators to relieve spasm within the limits of the patient's blood pressure. Keep the foot warm, also a general recommendation. And again, you should really watch out not to perform unintentionally vessel perforations. If the lateral plantar vein diameter is small, ensure the foot is adequately prepped. Yeah, if the S-mark bandage is really strong, tightened, so that you can increase the venous blood flow. After access, I usually do a venogram roadmap to assess the visibility of the pedal loop and help me to guide the guide wire upwards. Yeah, and I highly recommend to use a soft shaped wire like an advantage guide wire, either an 014 or 18, and whenever it is possible, administer some vasodilator to open the venous system and get more flush. Of course, on the other hand, the arterial access also need to be done very careful. Standard is, of course, come from arterial access as usually. On the way down, treat all inflow disease in the SFA on the popliteal artery. This is important. Again, you need at least a 7 French sheet to access with the arterial crossing catheter. So this is definitely recommended. So treat everything before you do the crossing, before you do the final steps of the arteriovenous, before you do the venous arterialization, so that no inflow disease exists at the end of the procedure. So when it comes then to the crossing, you see here the crossing system technology, which is now available as a 2nd generation technology. You see the device on the arterial side. This is the catheter with the tip, and you see it looks like a improved go-back catheter or improved other B-back catheters, which are available as well. But with the long needle, as you can see here, it is very easy to stick into the nitinol cage, which comes up from the venous side. again, the arterial crossing catheter, but this second generation is a catheter which only needs 6 French. In the past it was 7 French, but with the new generation it's a 6 French catheter. And the venous catheter is a 4 French catheter with this nitinol basket, which you then can open and stick with the needle from the arterial side into this basket. This is how it looks like, a little bit more closer look. See, you have to align these both devices. I'm going to say based on the cases we did, it's not very difficult. You just need to align on an AP view and a lateral view, and then you can deploy the needle towards the nitinol basket, and then usually the wire, the non-hydrophilic coated wire, then easily targets into the basket, and then the basket catches the wire, can close the basket, and then pull the whole wire within the basket down to the venous access point, and then you have a pull-through wire, which you then are able to perform the next step. Here you can easily see the different steps here. Try to film it here. You see the poking of the needle into that basket here on the venous side. Then once you are in the basket with the wire, as you can see here, advance the wire a little bit, like here in the third angio. And once this is achieved, you then close the basket, and then you can pour everything down in the venous system to the axis of the venous system here. Hope it runs. Yes, the basket closes, and then we are pulling the wire, the snared wire, to the distal venous access, and we can even take it then out. This is recommended. And then you have a pull-through wire, so you have a secure proximal and distal wire end, and with that you have a secured AV access, which you then can use for the further steps of this procedure. Then the next aspect is to prepare the AV fistula with a balloon. I recommend either to use a 3.5 or 4 millimeter low crossing balloon and perform a very proper dilatation at the crossing point, as shown here on the left picture. Then, once you have created that AV fistula with this ballooning, the next step is to perform a valvulotomy procedure to destroy the valves. A dedicated valvulotome is provided in the kit, the lymph flow kit. It's a 4 French outer diameter catheter, a push valvulotome. Show you in a second how it works. It's a self-expanding laser cut 19/3 cutting blades, and with this you really should destroy the valves. This is very important to create then the inflow. Here you can see on the right side, hopefully, how this tracks via the wire over into the foot, and you should really go very distal as well into the lateral plantar vein to destroy valves in this area. And then after this, after very intensive valvulotomy procedure, you then crack the resisting problems within this valvulotomy area with an inflation of a 5 millimeter balloon to nominal pressure. Yeah. You should not have at the end, like seen here, still dog boning of this balloon. You should really see that the balloon opens nicely. So this should be done the whole way from the lateral plantar vein up to the close to the AV fistula. With that, you have a perfect preparation for the final step, the stent implantation. You see the provided stents within the lymph node. Of course, other possibilities might be a Viabahn, which we also use in these kind of scenarios. But here you see the provided lymph flow stents. These are stents up to 200 millimeter now on the generation 2. In the past, they were quite shorter, just the 100 millimeter, but now up to 200 millimeter available. Self-expanded covered stents. At the end for the AV anastomosis, there is a tapered stent available. which is highly recommended to overlap these stents by at least 10 millimeter, so that no problem of migration could occur after stent implantation. So where to start with the stents? Here you can see in the middle picture the typical landing zone for the distal landing zone of the stent. So it's typically the approximate 2/3 of the calcaneus, and then of course the whole way up in the positive vein until the crossing, and then you do as a final step the tapered stent implantation. Again, approximately 1 centimeter of overlap is required, so it's usually 3 to 4 stent struts which should have overlap so that you don't have any problems of migration or dislocation. And of course, at the end, the proximal tapered crossing stent should be deployed less than 2 centimeters into the artery, so usually 6 to 8 stent struts at the final step should land in the artery. Post-stent angiography after post-dilatation, of course, is important and highly recommended then to see if we have a complete outflow loop. Yeah? If this is not the case, so that you have an incomplete, not satisfactory outflow, then you should definitely check what the reason for this is. Is this a spasm? Is there kind of the still a persistent valve which blocks the in and outflow? This has to be definitely checked and ruled out. And if this is a very diminished flow into the foot and forefoot via the deep venous system, then you definitely need to work on that, because otherwise thrombosis could occur of this venous arterialization tract. So inflow is key, outflow is key, and therefore a final good angiography is absolutely important. And for example, you see there's a persistent valve here in the mid part of the lateral plantar vein, persistent. So this needs to be corrected, and maybe again with the valvular tone destroyed. Otherwise, you have an issue with outflow and again of acute thrombosis risk. Yeah, then of course you need to do a good hemostasis in this area. Once you take out the sheet, this can be done by a 5-minute balloon angioplasty. This is not a problem. You can use your fingers to compress this anyway, but this of course needs to be done. If again there's a problem of persistent valve issue, you can still do valvulotomy to perform this, and at the end you want to see this picture. Yeah, you want to have a fast inflow and a fast outflow. So this is definitely important. What you also need to check, if there are some stealing tributaries or side branches which blocks the inflow into the foot and forefoot. If this is the case, you should then go for coil embolization of any tributaries or side branches which might be a problem for the inflow to the foot and forefoot. Yeah? Therefore, the final angio consideration is, do we have a complete arterialization formation? This is important. The final angio should definitely be done via the groin axis. Spasm is a problem. Yes, that's true. Spasm could still be a problem, especially after sheet removal, or if you still have a wire in place, then take out the wire, give some vasodilators like nitro or anything else. And again, discuss branch embolization if there are any competition tributaries or side branches which block the direct flow into the foot and forefoot. So at the end, you want to see this, a good inflow, a good outflow via the posterior tip vein. Over the time, you will see that this circuit maturates after deep venous arterialization. This is a follow-up after 12 months venous arterialization. You see the baseline, no option situation. You see the acute result. You see after 4 months, the maturation, and after 12 months, the full venous arterialization, even to smaller side branches, even to the heel in this case. to the very forefoot or even to the digits. So there's a clear maturation procedure after deep venous arterization. After the procedure, as I already mentioned at the beginning, it is very, very important to have a good monitoring of the patient. If there's not a significant swelling and the symptoms improve, the patient can be discharged very soon to the ambulatory field. If we have some moderate pain swelling, you should keep the patient for a couple of weeks, maybe in the hospital. Discharge the patient by close monitoring in your institution. We usually see this patient after 2 to 3 weeks just to check if this moderate swelling situation is not leading to a superinfection of the bones, which is absolutely important. And if you have a very severe pain and swelling situation, keep the patient admitted for a longer time until the bones are stable, until the swelling resolves and improves. If you see any signs of wound infection, start immediately and fast with calculated antibiotic therapy or even a systemic application of antibiotics. So it's very important then to keep the patient in the hospital on the ward to follow up the patient so that you don't miss any bacterial superinfection issues and catastrophes, especially in these severe swelling situation of the patient. This is the final angio after 12 months. One of our patients here, actually, you can nicely see the vein has become an artery. You see the nice biphasic flow here. This is provided the biphasic flow here by Roberto, as you could see here on the right side. This is what we want to see here after 12 months. This is a successful patient who had no amputation, a good wound healing, and this is what we want to see after 12 months. So with that, I'm done in this first part of this discussion round this afternoon. So I'm open for any questions, comments, and remarks. Thank you very much.
Thank you very much, really. It's a very knowledgeable presentation, really. It was great. Thank you very much. Looks you have a great experience, you know. I'm still surprised why still many people say doubt this technology, even though we have like many trials now. We showed it works. We know it works. I'm sure until now we don't know how exactly it works, but we know it works. And the reason why we still have 20-30% people end with amputation, even with a patent bypass, you know. So I think is any threshold for the tissue loss to say, okay, this is will not benefit from DVA? Is any like threshold or any other anatomical like location or distribution to say this patient is not good candidate for DVA? And the last question, can we do it for rest pain?
So rest pain is definitely an issue. Once such no option patient is revascularized, the pain usually increases because of the severe venous filling. This high volume venous filling is usually typical painful for this patient. So what we usually do with these patients, we keep the patient for at least 1 to 2 days within strict bed rest with a slightly elevated foot, not even allowing to stand up in front of the bed. So really is important to keep this patient for 1 to 2 days in the bed, monitor this patient for any complications before we then move forward this patient to remobilize the patient. Yes, it's true. The patients where the 30% of the patients who still got amputated are patients where we probably did not do a good job in terms of screening, especially in terms of wounds. I showed you this picture, which wound areas should be checked there. So digit dry necrosis patients are the perfect patient in my view, in my opinion. Metatarsal wounds are a problem in many cases sometimes, especially if there are signs of superinfection, then I would definitely not recommend to treat these patients. any signs of superinfection need to be controlled before we then do deep venous arterialization. So you need best our patient is a dry wound patient, no signs of superinfection. Patient with heel or ankle wounds are definitely no good candidates.
Thank you very much. Dr. Jamal, I see your hand up. Dr. Jamal.
Sure, thanks. Once again, thank you, Professor Michael, for your very valuable presentation. For the audience, this presentation was supposed to be during our PAVSS meeting in Riyadh in December, and for various reasons, we were unable to have Professor Michael with us, and we thought this will be a great opportunity to have it as a separate session because of its importance and its value, especially for those patients where we think there's no more options except a amputation. And clearly we're seeing that there are options. And in fact, in some of those delayed pictures that Professor Michael showed us, we even saw revascularization to the heel. We saw these small branches going to the heel, even though the heel was not a good vessel, a good area for considering the patients for revascularization. My questions are the following. You know, many of us here in the Middle East are in areas of limited resources. So number one, what is the learning curve? How many of those, how can we get our experts here to become competent at doing it? I mean, you go in and you want to do it, and you try to stick that lateral plantar vein, and you miss it, you puncture it, and it bleeds. And I mean, so what is the typical learning curve? What are the ways we can get our interventionalists and the vascular surgeons to get this technique up and going? And the second thing is the cost. Many of our patients are self-payers, so they have to pay themselves for this procedure. And some of them in my part of the world may even have to sell a piece of land to come in and get treated. So if I have them spend a lot of money and then end up with a failed bypass, a failed intervention, I mean, I have a lot of explaining to do. So can you help us with those? How can we become good at it, and what is the typical cost, etc.?
Yeah, maybe we can involve you also, Hani, so get not only a German opinion here, so as well as a UK opinion. Hani, what would you answer in terms of cost, especially?
Yes, so just to say, fascinating talk as always, Michael. Very detailed, very fascinating and interesting. I think the cost is an issue, and Jamal, you raised a very good point. But like any new technology, the more we use it, the more production will take place, and the cheaper it will happen. And I think it's now beyond even the cost, because the manufacturer or the company is not able to provide or supply the material outside sort of the Europe and the US.
So, but take the cost away. I mean, first, people will be willing to pay if you guarantee them it's going to work. So how can we get to the level of being competent at doing it and say, okay, we can do it?
This certainly one point you raised is the learning curve, but it's not a steep learning curve. So I can tell you, for example, when we started, and Michael has a far bigger experience. We used to do this procedure. It takes 5 hours. The last one we've done took 95 minutes. And it's an area in the foot, especially for surgeons. We're not used to it. So, I mean, if you look at us, we've never scanned lateral plantar vein before to try to access it. When you do distal and alterdistal bypasses, the posterior tibial vein is something we push with the scissor. But now we have to treat with respect and sort of learn how to access it. But it's not difficult. So I would say probably 2 cases proctored, and then you should be all right if you have already the setup. Would you agree with that, Michael? Or?
Absolutely, yeah. I think the most complex thing is to deal with the venous system. Fully agree. Yeah, but this you learn after a handful of cases, and you know how to treat. Of course, there are sometimes these colibri patients who show some anatomy severities, which are complex, but I agree. The learning curve for someone who is in the field of endovascular space, yeah, it's manageable.
Yeah. Can I add, Jamal, you don't have to be very expensive. Lymph flow is a whole system, but you can use something cheaper. And I'm sure, guys, you have like the gun sight, technique, which is you just put a needle through into, basket, and you get a wire, you can snare it from both sides, and you get through it, So you don't have to spend too much, expensive, and you can use a Viaband. We already have it there. So, and Velvoton is there. So lymph flow is very nice, but, the whole set with you. But if you don't have it, I think with whatever small, what you have, sometimes you can manage it, it's less expensive, I think. Hani, you still have your hand up?
Yes. So just 2 points. The first thing, which is Mike highlighted very elegantly, is that this is it's a program. It's not a procedure. So most of the people pay attention to the procedural details, but actually probably the success comes from before the procedure with the patient selection and the setup, and the intensive input after the procedure itself in terms of wound care, antibiotics, sort of the concept of focalization and embolization. But my question to Michael, and I would like to learn from your experience regarding the medical management post-operatively, because when we started doing these cases, we started to treat them as tibial angioplasties, and we used to put them on dual antiplatelets. After some time, this appeared to be sort of not enough. And now we move to treat them as if they are deep venous stents. So we put them on DOAC, direct oral anticoagulation, plus an antiplatelet. Are we overkilling it, or what is your protocol? What do you do? Or do you have like a strategy or algorithm?
Yeah, very important question. And unfortunately, we made the same experience when we started 10 years ago, that a dual antiplatelet therapy is not enough to keep the deep venous system in the foot patent. So you need to have anticoagulation. So my regimen now is antiplatelet therapy plus DOAC, because this is easily monitored and can be easily taken by the patient. So whenever it's possible, no bleeding complication, etc., I use clopidogrel plus DOAC for a long time. If it's from a clinical side, okay. Dual antiplatelet is definitely not sufficient in my view.
Okay.
Okay, Carlos, your hand up.
Yes, thank you. Yeah, really fantastic talk and experience. Thank you so much. So two questions. The first one is relatively short. I mean, obviously it's a long procedure, so I'm going to stick to complex aneurysms. I'd rather do that than spend 5 hours, but obviously it's much needed. How much coil embolization is necessary? Like which or how many tributaries that you see and be like, okay, I have to embolize this to prevent postal pain or steel. So because it's a long procedure. So that's my first question. My second question is, is more about control of this procedure. Like now, I see a lot of patients having TCAR where be like, why didn't you do CA? You're like, oh, it's a high lesion. And you look at it. No, it's not. I mean, so how can we keep this good open surgical skills? Like, I don't know what we will be doing in Germany to control these patients where you might say patient, maybe there's potential for distal bypass instead of doing lymph flow or any other techniques. Thank you.
So this is a very good question. At the end, you know it after a couple of days if you should have embolized something or not. We don't know by yet what is enough inflow, what is not enough inflow. What I definitely learned is that if there's a big tributary very proximal at the level of malleolus, stealing a lot of blood flow so that at the end the contrast is diminished going to the foot and forefoot, then I'm very open for embolization right away. Whenever I'm in doubt, should I go, should I not go for embolization, I put the patient back on the table 3-4 days later, or maybe sometimes even 2 weeks later, just to see how this maturation goes forward, if there's still an issue. On the other hand, if there are some stealing tributaries, it prevents from this massive swelling. So you have to dive a little bit through. But I definitely can't give a general recommendation when to embolize and not to embolize. So I have to see it from every patient. Of course, if there's an absolutely slow flow or no flow into the forefoot, then you need to do it. If you're in doubt, then put the patient a couple of days later on the table, 2 weeks later, and decide if you then go for embolization.
Great. Dr. Muhammad Omar, Farouk, you have your hand up?
Yeah. Thank you very much, Michael, for again another fantastic lecture. I have two quick questions. Number one, do we need to study the foot venous anatomy by CTV before we indulge into this procedure to know the exact anatomy, or just rely on the on-table venogram? This is number one. Number two, I have attended this procedure probably with 5 different consultants in many different continents. And because the system is expensive, as Samer said, the double snare technique was getting the needle, the off-shelf devices. There are many off-shelf devices other than line flow because of the reason of the cost. But even this is not standardized. And when you go into minute detail, how much collateral do you leave and how much do you embolize? How much you do valvotomy? Is it until the ankle level or a little bit below the ankle level, and what diameter? Do you think an era will come where we have this procedure standardized, like the carotid endarterectomy, for example? Or is it going to evolve for another few years? So this is my 2 questions.
I think we are still in a learning process for this procedure. We all are definitely learning from each case.
Yeah.
So in terms of valvulotomy, I do it as distal as I can. Yeah. And if there's still inflow, outflow issues, I even do then a balloon angioplasty. What I can tell you in terms of alternative products, I would not recommend scoring devices in this area. We learned also from animal tests with the lymph flow that scoring of lateral plantar vein or the pedal arch can cause much damage, deep damage, vessel wall damage to the veins. So avoid scoring balloon angioplasty. Standard balloon angioplasty is not a problem. So therefore, try to get the valvulotome as distal as possible, close to the plantar arch itself. This could be sometimes difficult, so you have to predilate and then go for the valvulotomy, but this is highly recommended. Avoid scoring technology. And as I said, yes, of course, we can use alternative products. We did, especially during the COVID time where everyone faced issues, especially supply issues. We used many alternative possibilities, BVAC catheter puncturing in a balloon, ballooning of the arch itself. I think what I personally definitely learned, the most important aspect beside of a wire barnless crossing is that valvulotomy to prepare the lateral plantar vein to create inflow. And it is the same like in iliac vein interventions. If you don't have inflow and outflow, this will fail immediately. Yeah. So this is absolutely key, regardless of the other steps, which you can definitely do with different other products.
Great. Martin, your hand is up, please.
Yeah, Michael, thank you for comprehensive lecture. We know this technique is working. I have many, technical questions, but there is no time for this. So only 2. First is, what is your threshold to go for venous arterialization? Because I know how pedant you are working in Arnsberg. So when you shoot the angio and you see the desert foot, you go straight away for venous arterialization, or you try to puncture hibernating arteries and stuff like that? That's the first question. And the second, is there any indication for like closure of this reconstruction? Because it's like permanent venous hypertension. So after the wound is healed, is there any indication you have to close this reconstruction to cease the venous hypertension?
So our threshold is still high. So we treat, we still do everything on a conservative, standard, endovascular, retrograde, et cetera way. So we are not probably lowering this threshold. The threshold lowering is maybe in discussion in terms of what is the indication. Is a Rutherford 3 patient which has no options, a patient to prevent Rutherford 4 and 5. And I think this is a discussion which now is ongoing. I think Rutherford 4 is definitely a patient which might be a candidate. Rutherford 3, I'm not sure. We treated some vasculitis patient actually which had no options in these patients. Rutherford 4, 3 plus we treated. But I think this should be definitely done on a very, very close monitoring. I personally never occluded a deep venous arterization such a patient. I'm not sure what do you mean with that, to prevent any complications after deep venous arterization?
These patients usually develop like the edema, which can stay for a long time, you know, and if there is any indication, you just have to close it at some point because of this.
But this would then lead obviously to amputation, probably, if you need to. What you can do is definitely check for the inflow, maybe tributary embolization to reduce the especially swelling of this patient, which can sometimes help. Actually, this swelling issue is usually solved after a couple of weeks, I must say. Yeah. It means the patient has to take good rest to elevate the foot. So I think it's control. You can control it. So actually in my 40 standard cases and around 10 to 15 off-the-shelf cases, Ani, I don't know what you think. We did not have this problem.
I just had 2 patients, you know, they healed nicely after the venous arterialization, and they were asking me, like, what we're gonna do with it, you know, after the foot was healed nicely. And I advised them to keep it working. So I'm asking if you have different opinion.
Ani, what would you say?
So in fairness, we didn't, we haven't come across this situation that we have to close the fistula. And the leg swelling, so there were always two problems that we sort of were trying to find a way around them, the pain and the swelling, as Michael mentioned. And we found that probably the best solution is that at the time of the procedure, all of them, they get a nerve sheath catheter put in for continuous infusion of local anesthetic. So they are able to lie in bed with the leg elevated, because without that, you give them like a venous hypertension with the swelling, but also there is some element of steel. So they have some ischemic pain. So they can't really keep the foot up. But with the nerve sheath catheter, which can stay for up to 7 days, you can keep them in bed for at least 48 hours with the leg elevation, and this sorts out the swelling quite effectively.
All right, we have many questions from the attendees, but I see Jamal, you have a quick question before we start the attendees.
Actually, go ahead with the attendees. I was just gonna ask you about to address the attendees, so I will.
Okay.
I'll drop my hand.
Oh, no problems. I mean, the first question from Dr. Mahmoud Bashir, which was say my question, that you see after you get a kind of arterial steel syndrome, because he already has a critical flow to the foot, and you do like a fistula, so you get a steel, so you get a rest pain. So how concerned about this rest pain? Does it cause more ischemia before it improves? Because it takes 4 to 6 weeks. And how we should deal with it? And should we be concerned about it when patients have a severe rest pain after the procedure?
This is what I mentioned, to monitor this patient and bring this patient to a certain time. Yeah, during this maturation time, this usually resolves and improves. So this is the importance we need to take care about, especially if the patient is once in the ambulatory system. Usually this pain resolves after 3-4 weeks, improves once the maturation moves forward and the effectiveness of this venous arterization moves. But this could be the hard time for the patient and the whole family indeed. Yeah.
Okay, another question. Do you have experience of open DVA? I think they meant